Good evening, ladies and gentlemen. Thank you so much for joining us from around the world. We've got attendees from at least 4 countries, if not more. Welcome to the first in a series of Global Child Health COVID-themed webinars from the RCPCH International Child Health Group. My name is Marika and I'm Deputy Convener of the group, and I'm today also joined by Paula, who's our Treasurer, who will be dealing with the technical aspects of keeping the webinar going, keeping us to time and keeping note of all of our questions. I'm currently a UK paediatric trainee undertaking a PhD where I'm based full-time in Malawi, where I undertake my clinical work at the Queen Elizabeth Central Hospital in Blantyre. And my colleague Paula is also a paediatrician who was until recently working at Oling During Children's Hospital in Sierra Leone. Whilst we acknowledge that evidence from high resource settings is that children are unlikely to be severely affected by coronavirus, the indirect effects of the pandemic on child health, particularly in low and middle income countries, are potentially catastrophic. The disruption to EPI, reduced access to care for treatment of non-COVID related infections, and the long-term effect of school closures and lockdown on development and the well-being of children are likely to harm a generation of children. In response to the limited priority being given to child health in the current pandemic, ICHG is organising a series of webinars. We aim that these sessions will bring together global child health professionals working on the COVID response to share experiences, guidelines and resources, and to provide a supportive forum for discussion at this time of much uncertainty. Today's webinar will focus on facility-based paediatric care in the COVID era. In future webinars, we will discuss protecting healthcare workers, including infection prevention and control and PPE, testing and transmission, protecting vulnerable children, and mitigating the long-term effects of lockdown and physical distancing. We are extremely grateful to welcome our 3 panelists today for giving up their valuable time to take part tonight to share their experiences. We will begin with an introduction and overview of COVID infections in children from Dr. Stephen Owens, followed by the challenges of delivering facility-based care in the COVID era from Dr. Helen Brotherton, who is currently working in the Gambia, and my colleague Dr. Jessica Chaziya, who I work with here in Malawi. We will then have an opportunity to answer the questions, many of which were submitted in advance, and then also to answer question and answers which you should be able to submit written during the seminar. If you wish to ask any questions going along, there is a facility that you can put your hands up, but to make things consistent, since we've had over 150 people register for this webinar, it will be easier for us if you can type them, and then Paula will filter them and ask them on your behalf. Great. So we'll get started. I'd like to introduce Dr. Owens. As a consultant in paediatric infectious diseases and immunology at the Great North Children's Hospital in Newcastle upon Tyne. He has a long-standing interest in tropical medicine and international child health, and has worked for several years with both the Liverpool and London School of Tropical Medicine and the Medical Research Council in the Gambia, culminating in his PhD on placental malaria. He was a clinical advisor to the NHS during the Ebola crisis in 2014-2015 in Sierra Leone, and is now clinical lead for UK emergency treatment team providing on-call acute clinical care to children in countries affected by sudden onset disasters on behalf of the UK government. He has been deployed to Bangladesh to help manage the diphtheria outbreak among the Rohingya displaced population, and most recently to Samoa, joining the multinational humanitarian response to the measles outbreak there. At home, Stephen is helping to develop Newcastle's clinical services for patients with higher consequence infectious diseases such as viral hemorrhagic fevers and MERS. Stephen, over to you.
Thank you very much, Marika. So my name's Stephen, and I've been asked to give you a kind of quick overview, really, of the literature as it relates to paediatric patients with COVID-19. I should start with a couple of disclaimers. First of all, this is my first Zoom presentation, so bear with me if things go slightly awry. And secondly, happily for us in Newcastle, compared to other parts of the UK, we've not been, to date at least, very heavily impacted by COVID, certainly compared to London and the Midlands. And having swabbed now over 700 predominantly symptomatic children, we've only had 14 positive cases, of which only 6 have been hospitalised. We have had 2 or 3 of the kind of recently recognised PIMS-TS, hyperinflammatory syndrome cases, and we can talk a little bit about that. I'm also conscious that pretty much everything I've got to say this evening comes from literature generated in kind of high resource countries, of which I include China. And there's been very little data published to date, I think, from lower income countries. But I'd be happy to hear the experiences of the rest of the panel and some of the questions that we get in response to the talk. Okay, right. So first of all, epidemiology. I don't know how well you can see this slide. I guess it depends how big your screen is, but it's really just to demonstrate that SARS-CoV-2 has now extended to pretty much every country or territory on the planet, with very few exceptions. And in most of those territories, the numbers of new cases are still rising, exceptions being Europe and I think the Western Pacific, where numbers have leveled out or even started to drop down slightly. That the epidemiology in children is very different to that that we see in adults, as most of you will be aware. Very few cases really comparatively have involved children at all. There's the slides, my last slide that I had there, I'm going to skip through actually because it is useful just to picture it. Just shows that probably less than 2% of all confirmed cases to date have involved children. And of those, adolescents probably account for at least half of those cases, and in some ways can be considered almost like adults in terms of their risk factors and the clinical course that many of them experience. We're aware that this may in part represent selective testing in the sense that, generally speaking, in most areas, only children who are symptomatic for the virus are actually getting the test. So it's likely that there are many more children with very few or no symptoms at all who are going under the radar. But nevertheless, even in community-based kind of prevalence studies, most notably in Korea and Italy and in Iceland, what we've seen is an attack rate really, which is a fraction of that seen in adults, even within households where there are kind of clusters of cases. And there's this idea, this suggestion that children may in part be resistant to infection through mechanisms unknown. Some have postulated that perhaps the expression of the ACE2 receptor in lung tissue means that they're less amenable to viral invasion in the first place, and some have postulated about differences in kind of pediatric immune systems that might account for this difference in infection and even symptomatology. But what is clear, I think, is that the disease in most children is very mild, as we've heard, and that deaths happily are extremely rare, although of course they do happen, and when they do, they're a tragedy for the families involved. The infographic on the right there is just a picture from Public Health England's weekly update on surveillance of COVID-19 in the UK. And again, just showing that inverted pyramid with paediatric cases represented by the small bars at the bottom. I think we've got about 2,500 cases involving children in the UK so far. About 5% actually of all of the confirmed cases, so slightly higher than in the general literature across the world. It seems that children can incubate the virus from anything from a few hours, in the case of some neonates, to a month or more. But usually by about 12 days, children are starting to shed it and have virus, which is detectable in respiratory secretions. There are some studies which have picked up certainly genetic material, viral RNA, in stool and in urine in tiny numbers of patients. And most recently, at least one report suggesting that viral RNA was present in breast milk. Although the importance of that genetic trace in tissues or secretions is far from clear. It's certainly not clear that the virus in these compartments is actually transmissible virus rather than just a kind of residue of dead or decaying virus. Seroprevalence studies are ongoing, and of course they're going to be vital in order for us to have a proper, true understanding of how the infection is proceeding through the different age groups and populations. But already I think it's becoming fairly clear that children seem to have a very limited role in transmission of SARS-CoV-2. I think that's becoming less and less contentious as time goes on. There are a few studies which suggest that they are as equally amenable to infection as their adult counterparts, but I think they're offset by an increasing number of studies which comment on low case numbers in children overall, lower attack rates in known clusters where every patient with a contact has been swabbed. Paediatric patients seem to be less frequently infected, and when the cluster studies have been done, in almost every case, an adult index case has been identified. There was a famous report from a child in the French Alps who was known to be positive, had contact with over 100 people at a resort, I believe it was, and didn't give the virus to anybody as far as could be known. This just shows the case definition used by WHO, which hasn't changed much since March when it was first published. Just really highlighting that a suspect case is anyone with any respiratory symptoms of acute onset who lives in or has travelled to an area where there's ongoing community transmission of SARS-CoV-2 in the last 14 days. Alternatively, a patient with acute illness who's had acute respiratory illness, who's had a contact with a known COVID patient can also be considered to be suspect, or anyone who's got a severe acute respiratory illness, severe enough to be hospitalised, for which there's no alternative diagnosis in the context of a pandemic may be considered a suspect case. Probable cases are those for whom testing has been inconclusive, or indeed testing has not been possible at all. They move from suspect case to probable cases, and confirmed cases are those who've had a laboratory confirmation of their diagnosis, usually by real-time PCR. Clinical presentation in children can essentially go from completely asymptomatic to acute respiratory distress syndrome and severe pneumonia, or really anything in between. Unlike in adults, it seems that perhaps as many as a third of all paediatric patients have no or very few symptoms at all. But what is clear is that critical illness in kids is extremely rare. So of the order of about 1% of children with this virus will become critically unwell and need level 2 or higher support in hospital. What is common instead is what you might describe as non-specific viral symptoms, cough and fever in about half, carousal symptoms in just under half, and then in a small but substantial minority, the presenting complaints is with a gastrointestinal illness of diarrhea and vomiting. There's increasing interest on various skin manifestations of the viral infection in kids. The picture on the right just shows what's been called COVID toe, a sort of chilblains vasculopathy type rash that occurs in a minority of children and seems to imply an underlying the vasculitis or endothelial dysfunction, which fits with some of the pathogenesis postulated for severe cases in adults and in some children. What's not been possible so far, unlike in adults, is to use clinical criteria to predict the likely severity and outcome of the illness in children, because there's such a variety of clinical signs and symptoms and such a high prevalence of asymptomatic cases. Moving on from that, as I say, unlike in adults, there are really no specific biomarkers for disease severity in kids. Often what you see is a slight elevation in inflammatory markers, CRP, procalcitonin, and a slight elevation in transaminases. Unlike in adults, lymphocytopenia, although it does happen in children, is actually uncommon, and radiology is often normal. When it's abnormal, the signs and described on X-ray and on CT scan are very similar to adult patients, namely ground glass opacities and areas of collapse or consolidation, such as illustrated in the picture on the right there. The gold standard test, as I say, is real-time PCR, nucleic acid amplification tests. The issue with those tests is that if the tests are performed very early in the disease onset or perhaps late, then their pickup rate can be quite low. And people talk about a sensitivity of somewhere between 60 and 80%, which is not great when you're trying to decide on your admission protocols and policies based on the test results and knowing for certain whether a patient has the virus or not. We've also found that some children will have viral co-infections with adenovirus or even influenza. And so the detection of one of these other viruses doesn't preclude a diagnosis of SARS-CoV-2. There's a lot of interest in the media and the literature at the moment about this PIMS-TS. This is a hyperinflammatory syndrome, stands for Paediatric Inflammatory Multisystem Syndrome, temporarily associated with SARS-CoV-2. It's a bit of a mouthful, which is why it's often given an acronym that plays on the fact that it's very similar to severe Kawasaki's disease. So you hear terms like Koronasaki or Sawasaki, I've heard. But the basic idea is that there's a hyperinflammatory syndrome which looks very similar to Kawasaki's disease, or even sometimes to macrophage activation syndrome. And the first reports really have just started to come out over the last few weeks. First from South Thames PICU retrieval service in the UK, and then with other cohorts from Italy and France being published at the moment. It seems that this inflammatory phenotype is a post-infectious phenomenon. It usually comes on 2 to 4 weeks after the likely viral infection has occurred. Often the patients are PCR negative on testing, but almost always the patients have IgM or IgG to the virus detectable in their serum when the tests can be done. There's some evidence that there's case clustering. So we see clusters of cases within geographical areas, which has led some people to wonder whether it's a particular serotype or serovar of the virus that's causing this particular problem, or there's no definitive evidence to prove that. It seems that children who belong to Black and ethnic minority populations and those who are obese are overrepresented, certainly in the UK, in these cases. And the children often present acutely unwell with gastrointestinal upset, fever, diffuse macular papular rash, and then can sometimes go into shock where there's cardiac involvement, myocarditis, sometimes aneurysms, and even cardiac failure. Inflammatory markers are usually very high. In terms of identifying groups who are most at risk from the virus, data are very sparse to date. It seems on very limited data so far that those who are immunosuppressed seem to manage the virus pretty well, actually. There are small cohorts from cancer registries, from those with inflammatory bowel disease, and a small number of kids who've had solid organ transplants, particularly liver transplants, all of whom can be considered immunocompromised or immunosuppressed, but seem to manage the virus without too many complications. However, when we look at the children who are very unwell with the virus and admitted to PICU, case series from Italy and the US suggest that kids with comorbidities are overrepresented in that population. And the comorbidities that seem to be particularly well characterized are those with respiratory diagnoses and kids with neurodisability. In other words, children who would suffer with any respiratory virus, or would more likely to suffer with any respiratory virus and find themselves in intensive care. It seems that very young children under the age of 1 may also be at a higher risk, but overall the complication rate from this virus in children seems to be equivalent to influenza. We're not seeing a huge increase in expected number of deaths in kids. Sunil Bhopal published a letter in the BMJ recently showing that the deaths from COVID account for a tiny minority of overall estimated pediatric deaths over the last few months. Unlike in adults, where we see this huge spike in expected number of deaths, which has been attributed to the virus. Neonates, there's been hundreds of babies born to infected mums now described in the literature. Most of them do extremely well. It seems that there's a small increase in the risk of preterm birth and fetal loss, but the data on that are not very clear at the moment. There's a lot of interest in whether the virus can be transmitted vertically, either during late pregnancy or perhaps in the perinatal period. Certainly, so far, studies of cord blood, amniotic fluid, and the fetal salivary placenta have not demonstrated detectable virus, to my knowledge. Obviously, there's new data coming out all the time, but certainly as of yesterday, I couldn't find any case reports or any series describing that phenomena. And most babies born to positive mums will themselves be PCR negative. However, there have been a few babies who've been PCR positive for the virus just a few hours after birth, having had very little in the way of direct contact with their mothers. Most of those babies happily do very well. There are others who are PCR negative, but serologically positive and positive with IgM antibody, which, as you know, is not transmitted across the placenta and therefore seems to have been generated by the baby in utero in response to intrauterine infection. The picture on the right there is a slide of some placental tissue showing some histological inflammatory changes in the placentas of babies who've been born and developed COVID soon after birth, obviously having been born to positive mums. Up until yesterday, all of the studies that had looked at breast milk reported that the breast milk was PCR negative for this virus, but I came across one report yesterday in which the virus, at least the RNA for the virus, had been detected. So that's very much an area of active interest. This is a very easy part of the talk because management for the vast majority of kids will be conservative or supportive. There was interest early on suggesting that non-steroidal anti-inflammatory drugs like ibuprofen could lead to a deterioration in the disease. But in fact, there's really not very much evidence to support that concern. And that's something that's still under review. Certainly the Royal College of Paediatrics and Child Health doesn't advise against the use of ibuprofen altogether where it's required, but simply states that one should start managing fever in these patients with paracetamol. There's lots of interest in various disease-modifying agents, anti-inflammatory drugs like biologics, which is ongoing at the moment, but nothing which shows definitively one agent is more effective than another. And there's also likewise studies of a variety of antivirals, which I won't go into here, and also anti-malarial drugs showed some possible beneficial effects in studies, observational studies early on, but subsequent large observational studies suggest that in fact these drugs are not helpful and may be harmful. The main issue, to my mind, in managing children with this virus is to make sure that staff are protected. And it's good to hear that you're going to have a separate session looking at infection prevention and control and various PPE options. I think the main thing, as I say, is to, where possible, try to isolate or at least separate out patients with this virus in order to reduce nosocomial transmission and particularly in order to protect staff members. Outcomes for the virus, as I've already kind of highlighted, are usually very good. Deaths are extremely rare and the short-term prognosis is excellent for most kids. I would just sound a note of caution to say that it's probably too early to understand whether there are any long-term complications from this infection in some kids. For example, reduced exercise tolerance, maybe some developmental delay, worsening cardiac function. In adult patients who've recovered, many of them have complained of this excruciating fatigue, which can continue for many weeks or months after the virus has been cleared. I think for most of us in paediatrics, certainly in the UK, we're becoming more and more concerned about the kind of collateral effects of the pandemic on child's health. People have described this as almost a pandemic of fear. We are worried about delayed presentations to emergency departments for urgent care. Some data published in the Lancet from Italy a few weeks ago showing a huge drop-off in emergency department attendance for kids across Italy. And that's something that we've certainly seen in Newcastle and are reviewing and analysing the effects at the moment. Some evidence from the States and indeed from the UK that there was a fall in uptake of immunisations through late March and April. Happily in the UK, at least, that's now picked up again. But this is something which is obviously a big concern in other parts of the world where healthcare services might be shut down or access restricted in response to this pandemic. It's really crucial that kids are still able to access their primary vaccination schedule. Some reports suggesting that the new diagnoses of diabetes and even leukemia is falling, and that's not because these conditions are not happening in the community, they're not arising in the community. It's possible that they're just not coming forward and being diagnosed. And many centres have cancelled all of their elective work and even outpatients completely. In Newcastle, we've just started to resurrect these work streams, but most of our outpatient work is still conducted over the telephone. It's really important that all of the measures that have been taken to date, which largely have been implemented to save the frail elderly from this awful virus, don't lead to adverse outcomes for general paediatric care, not just in the UK, obviously, but across the world. And that's something that we really need to think carefully about and do our best to try to combat where we can. I think I've rambled on a bit too long. Sorry for the technical hitch early on. These are just some of the sources of information. Really recommend Don't Forget the Bubbles, which is a regularly updated literature review and summary site looking at the evidence of COVID-19 in kids. Absolutely phenomenal. And congratulations to everyone who's been involved with that. Royal College of Paediatrics and Child's Health also publishes its own review of the evidence, I think, which overlaps quite a lot with Don't Forget the Bubbles. And the Lancet has got a great resource centre where all of the publications related to COVID-19 are free. And that's about it from me. Happy to take any questions if there are any.
Great, thank you so much, Stephen. That was a fantastic overview and introduction, and great to have a summary of everything that's been happening in the UK. So I think now we're going to, see if we've got questions. So we've not had any questions so far. I think we'll have questions to the panel jointly at the end. So next we're going to hear from Helen Brotherton. Again, we're very grateful for her time. Helen is a consultant in general paediatrics with a special interest in infectious diseases based at the MRC unit in the Gambia. She's also assistant professor at the London School of Hygiene and Tropical Medicine and a Wellcome Trust training fellow. Helen undertook clinical paediatric training in Australia, London and Ireland before completing the diploma in tropical medicine at the Royal College of Surgeons, Ireland in 2007. From 2007 to 2009, she worked clinically in the Gambia as an RCPCH VSO fellow. Thereafter, she completed her clinical paediatric specialist training in Edinburgh, where she continues to work clinically as an honorary consultant paediatrician at the Royal Hospital for Sick Children, Edinburgh. She completed the postgraduate diploma in paediatric infectious diseases at Oxford University from 2010 to 2014. Her research interests are in hospital management of small and sick newborns, healthcare associated infections, clinical trials and implementation of hospital-based quality improvement measures. Thank you so much, Helen, and I'll hand over to you.
Thank you so much, Marika, and thank you so much for inviting me to speak in this webinar. It's really a pleasure, and I'm especially looking forward to the discussion at the end and learning from other parts of the world. Thank you. So the COVID-19 situation in the Gambia, I just wanted to give you an update. So we are very fortunate that so far we've only had 25 confirmed cases in the country. 16 of these cases were imported. Initially, these cases came from Europe and one from Southeast Asia. And more recently, the cases have been coming in from Senegal, which surrounds Gambia by 3 borders. The rest of the cases have been so-called local transmission, contacts of the index, imported cases, with one case where it wasn't really clear where the infection was from. There was no foreign travel or contact. So that's the situation so far, and very fortunately most of the patients have been asymptomatic or very mildly symptomatic. One patient died and the coronavirus was picked up on the post-mortem and the sample taken from the post-mortem, and there has only been one child affected so far who was 7 months of age and has recovered and been discharged. So after the second case of COVID-19 was diagnosed, the Gambian government instituted a state of emergency, which has now just been renewed for another 21 days. So really, since the beginning of April, end of March, beginning of April, all the air and the land borders have been closed, although we know that the borders are very porous with Senegal, the closest neighbour. So all positive cases of COVID are admitted to mostly the Ministry of Health Treatment Centre, but also we've had cases admitted to the MRC Clinical Services Department. All contacts of those cases are kept in quarantine, and also people entering the country from neighbouring Senegal are also kept in quarantine for 2 weeks. So although this is my disclaimer, like Stephen's, although we have had so far a very low incidence of COVID-19 in Gambia, we've been working incredibly hard over the last 2 months with colleagues at MRCG and also the government colleagues in preparing for what we expect to come. And we are expecting increases in cases over the coming weeks and months, although some statistical modelling done by colleagues here at MRCG predicted by this time we would have hundreds of cases, which hasn't happened, thankfully, but we're not letting our guard down. So the MRC at the Gambia, which is part of the London School of Hygiene and Tropical Medicine, our role in the COVID response has been 3-pronged to date. So first of all, we've been the main testing centre conducting real-time PCR here at the molecular laboratories. And this has been ongoing in parallel with collaborating with the Ministry of Health to really expand testing to the National Public Health Laboratory. So as of last weekend, COVID testing is now happening at the Ministry of Health main laboratory, as well as at MRC, which is fantastic. The second part of the response has been the clinical care that we've been providing. So we have 2 isolation rooms at the CSD department, and we now have 4 wards with over 40 beds exclusively for COVID patients if we need them. And we admit a mixture of children and adults, although there's no maternity or neonatal services at the clinical services. Also, we are obviously involved a lot in research, and our focus has shifted recently to focus more on COVID research, although other research projects are now restarting after temporary suspension. So there is active surveillance is going on based at the Clinical Services Department, looking for influenza-like illness in patients presenting with respiratory symptoms with onset within the last 2 weeks. And this is really an excellent use of research, because this community surveillance will contribute to us picking up community transmission earlier if and when it happens. There's also research involving genomics and whole genome sequencing of the SARS-CoV-2 virus that have been identified to date. And there's a lot of planning going on for randomized control trials looking at different interventions, household transmission studies, and social sciences research. So just to give you an idea of what's going on in the Gambia, and these are some of the treatment facilities you can see in the pictures. So it was really amazing. Within 10 days, the facilities department had erected these temporary, but they really are permanent structures, which have 10 beds inside. So we have 2 of these, and we've converted the clinical services seminar room into a 3rd ward. So we now have 4 separate areas plus 2 isolation rooms for the cohorting and the management of COVID patients if we need them. And that's in addition to 2 wards which are for non-COVID patients. So the Clinical Services Department here, our remit is really to provide medical care to the unit staff, of which there's over 1,000 staff and their immediate family members, to study participants, and particularly, for a lot of the clinical trials, vaccine trials that go on here for their participants. And also we do provide services to the general public. So across the Gambia, there are 3 sites that the MRC has clinical services. The largest of these is in Fajara, that I've explained, and then we have Kenaba and Basse. So it really is covering the whole length of the Gambia. So just thinking about some of the challenges that we've been thinking about in how to provide care to children and adults with COVID, is we've been thinking about how to cohort and what will the patient flow be like. And I think this has been a challenge, as Stephen mentioned, in all settings we're going to face similar challenges. And really how we respond to them depends on what resources we have available, what space, what staffing, and what abilities for testing do we have. So some of the planning work that we've been doing, and with Dr. Karen Forrest, who's the head of department, has really spearheaded this, is to change how we see patients when they come to the outpatient and the triage clinic. So this work is just about implemented. As of next week, this will be fully operational, but we've changed the flow to have a hot zone. So when patients come to the clinic gate, they will be triaged, there will be a nurse checking a temperature and asking for any respiratory symptoms. Patients who have respiratory symptoms will be sent to the red areas. So this is the hot zone, where they will undergo another more detailed triage, and then they will be seen by doctors, either as a new presentation or as a follow-up and an outpatient coming back for appointment. If patients don't meet the criteria to go to the hot zone, they'll just be seen as normal in the gate clinic and the outpatient department. So, I mean, this system is very good, and it's needed a lot of work to put in barriers, build new toilets. There's been a lot of resources that has gone into making this operational. But the intention is really to try and reduce the risk to the other patients, but also to the healthcare staff. And it means that we can cohort the use of PPEs in the hot zone. But a lot of resources are needed for this. Basically, we're duplicating the outpatient system. So we've also changed the setup of the wards. So we will have the COVID hot zones, and we will have the 2 wards where patients without COVID will be managed. And we're also anticipating that we may have patients with suspected COVID, but who are PCR negative, but which we strongly suspect them to have COVID. And those patients will be cohorted together in one of the wards. Specifically for children, as Stephen really nicely outlined, we know that a lot of children are going to be asymptomatic or have very mild symptoms. So it's possible they'll be admitted with a different condition when community transmission is ongoing. They'll be admitted with something else and we may not necessarily know, and we consider them to be very high risk for the healthcare workers looking after them. So we've decided to look after all children together in one ward with physical distancing between the beds, and use the healthcare workers to use PPE whenever they go into that one ward. So another challenge which we will invariably face is around the clinical management. So we have at the moment on the CSD, there is oxygen, IV fluids, proning and antibiotics. There is one bubble CPAP machine which will be kept for neonates who don't have COVID, anticipating that when we come into the RSV bronchiolitis season, there will still be a strong clinical need to use it for bronchiolitis patients. And we are developing, there's some very innovative work going on here at MRCG with the biomedical department, innovating some CPAP devices using snorkeling masks, which will be used for adults, and also adolescents could access that. But we will expect to have possibly 4 or 5 CPAP options, CPAP machines. We are very lucky that we have investigations. We have excellent microbiology, hematology, biochemistry labs. We also have a portable X-ray and access to an echocardiogram. So, I mean, they're the facilities available here at MRCG, but some of my colleagues in other Gambian health facilities don't have access to those same investigations. And what we're planning here is to have a treatment escalation plan at the time of admission, recognizing that our resources are going possibly, hopefully not, but possibly the resources are going to be stretched, and we may have situations where we don't have enough oxygen or CPAP for all of our patients. So we've thought a lot about this here. We've set up a working group looking at resource allocation. And at the time of admission, we will have a treatment escalation plan where, depending on the comorbidities, for example, if the child has tetralogy of Fallot or some other congenital heart defect, or they have an underlying condition, which means maybe we wouldn't want to escalate care, then we will have that very clearly outlined, thought about and discussed with the family at the time of admission for all patients, adults and children. And then specifically for children, we want to avoid nebulizers. We've been working with a 3D printing company to make 3D printed spaces available, which will be single use. And we've also been thinking a bit about resuscitation. I mean, we know that children who have severe COVID is very unlikely, but in the event that we have a child or an adult with severe COVID, we only want to do active resuscitation if there is a potentially reversible cause, recognizing that we do not have critical care facilities, and the act of resuscitation ambu bagging is possible to generate aerosols and increase the risk of transmission to healthcare workers. But more importantly, we know that if they're at the point of needing resuscitation, there will be very little ongoing supportive critical care that we can offer. So I think thinking about these things early, talking to the staff, having very clear plans is very important in the planning stage. And to help us with that, we set up an independent advisory committee made up of senior Gambian doctors, nurses, and representation from the ethics committee to really help the frontline staff with some of these difficult ethical decisions around resource allocation. So another challenge we may face is recognition of severe cases, and particularly the PIMS-TS syndrome, which Stephen outlined. We're currently updating our guidelines. We've got clear clinical guidelines for adults, children, pregnant women and neonates, and we're currently updating those with information about how we're going to address PIMS-TS. I think in our setting, I'd be interested to know if people in the audience have experience of this already in sub-Saharan Africa. But we're expecting challenges because of the overlap, the clinical overlap with sepsis syndromes, severe malaria, and the potential for late presentation. I think a very pragmatic approach in our setting is to have a high suspicion if children have persistent fever despite paracetamol, despite 24 hours of antibiotics, and if they're developing the mucous membrane symptoms and the rash, although that will be very difficult to tell in our patient population. So because we have access to echocardiograms, we're planning to do an echo at time of admission if we have a child with suspected PIMS-TS, and then also at 6 weeks later to identify coronary artery abnormalities. If they meet the criteria for Kawasaki disease, we will treat them with aspirin, and that will be on a consultant-led basis, and we will be very cautious with fluid use as well, as per reports coming out of the UK and elsewhere. And I think it's really important that we think about what active surveillance can we do for this? You know, is there anything we can do as part of a network? Can we use existing research studies which are already looking at sepsis syndromes in children, like the PERFORM and DIAMOND? And can we use those structures to see what data we can pick up about these children and how prevalent it is in Africa? So as Stephen touched on as well, the next challenge is really how to maintain routine services and reduce the indirect effects of COVID for children and neonates. The recent modelling study that was published in the Lancet Global Health estimated that between 250,000 and 1.1 million children aged under 5 will die due to the indirect effects of COVID. And we already know the challenges that people are facing and that healthcare workers are facing on a day-to-day basis. And these are going to really be compounded by COVID. And the disruption of health systems, for example, once you set up a treatment facility for COVID patients to go there, it needs to be staffed by people. Removing nurses and doctors from already overstretched clinical services, such as neonatal units, will undoubtedly impact on the level and the quality of care that can be provided. Disruptions to procurement flows, to medications, all of these things are expected to have a huge impact, and particularly the EPI and the vaccination schedules. In the Gambia, the Paediatric outpatient department has been closed for the last 6 weeks due to COVID. I think there's thoughts about restarting that. But at the moment, those children are not being seen for any outpatient assessment. And some of the vaccination clinics have also closed. But it's not just the lack of the clinics themselves, it's the whole lack of access to healthcare. Public transport costs in the Gambia have doubled because of the state of emergency mandate that the public transports can only carry half the passengers to enforce physical distancing. So for people to come and attend follow-up clinics at hospital or their nearest health facility is incredibly challenging. The effect on antenatal care, health facility births, we've made incredible gains over the last few decades in terms of getting pregnant women to deliver in health facilities, and we're just beginning to reap the benefits of the improved health facility and antenatal care. And I'm really, really concerned that COVID will put back a lot of the gains that have been made in this area. So I think we really need to use our voices as paediatricians, as healthcare workers, as in whatever way we can to be advocates for children and to try and encourage access to healthcare as much as possible. So the Paediatric Association of the Gambia has really been doing fantastic work in this regard. It's a new association. It just set up about 6 to 8 months ago. And they've been advocating with the local EPI unit, with the Ministry of Health, with the WHO and UNICEF to try and encourage that the vaccination clinics continue. So if I could just take a few minutes to talk about really my passion, and which is kangaroo mother care and the care of the small and sick newborn. So I'm really very concerned about the effect that COVID is going to have on KMC and neonatal services. So over the last 3 years, I've worked with colleagues at the main neonatal referral unit in the Gambia to establish a 8-bedded KMC, continuous KMC unit for preterm babies. And it's really critical that we continue kangaroo mother care as much as possible. The WHO recommends that KMC should be continued unless there is a clinical reason from the mother or for the baby in which it should be stopped. And this is the case for women who are COVID positive, for babies who are COVID positive. So we really need to encourage it as much as possible. It's a life-saving intervention. It reduces mortality by 40% compared to incubator care, which is an incredible public health intervention. But I think we need to be proactive, and we need to think about how can we adjust the services in order to maintain the safety for the women and their babies and the healthcare workers without compromising the quality of the care that is provided. So some things that I know that the KMC unit in Banjul has been considering, and which has already started to implement, is thinking about visitors who come to the unit, or they already had a visitors policy, but to really actively think about how can we give these women the support that they need. Often they have their mother or a sister to help them do KMC, but how can that be done in a very safe way? For example, only one person in the KMC unit at a time per baby in order to prevent overcrowding. How can the beds be spaced separately, at least 2 meters, in order to make sure that the women are practicing physical distancing from each other? Ensuring we provide adequate hand hygiene. I think one of the silver linings of the whole COVID-19 thing has been such an emphasis on hand hygiene, making sure there's enough soap, that there's enough running water, which can be a challenge, and making sure that women have access to face masks so they can avoid horizontal transmission. And we've also been thinking a bit about the follow-up appointments. So instead of seeing babies every week, is it possible for some of the bigger babies to be seen every 2 weeks or every 3 weeks to try and reduce the gathering of women at the follow-up appointments, and also to ease the financial burden on them for coming back and exposing themselves on public transport frequently. And thinking about the discharge criteria, is it possible, as long as it's safe, to adjust the discharge criteria slightly to enable faster discharge so these women can continue KMC at home and avoid the risk of nosocomial COVID transmission. So thank you very much. I'm looking forward to hearing some questions and having some discussion. And there's my contact details if you'd like to get in touch.
Great, fantastic. Thank you so much, Helen. That was really interesting. It's clearly a huge amount of innovation and legacy interventions going on, and so much to think about. We've had quite a few number of questions, and we're actually running quite short of time. So I'm going to ask you if you might answer them on the text. I think you should be able to see them. And then I'm going to proceed to have our final speaker talk, which is my colleague, Dr. Jessica Chaziya. So she is a Malawian general paediatrician working in the busy paediatric department at the Queen Elizabeth Central Hospital, a tertiary referral institution and university teaching hospital located in the south of Malawi. She is an interest in infectious diseases and paediatric neurology, and she oversees the unit's malnutrition and chronic illness wards, and is our paediatric HIV focal lead. During the COVID pandemic, she has co-led the Queen Elizabeth Central Hospital paediatric COVID team, as well as being an active member of the hospital COVID response, the National COVID Case Management Committee, and health facility preparation trainer both at Queen's and in district hospitals. So welcome, Jessica, and we look forward to hearing from you.
Thank you, Marika.
Thanks. Are you able to turn on your video, Jess?
Sorry, so like Stephen,
yeah,
is also one of my first Zoom call, so I'm trying to navigate through. Is it fine if I just talk through?
Yes, that's fine.
And can you see my slides?
Yes, we can.
Okay, all right. So thank you very much for asking me to be part of this. It's very interesting to hear about what other people have been doing, and I've learned a lot from Helen's and Stephen's presentation. So I'm going to go through what our experiences, our team's experiences have been in Malawi, navigating through pediatric care during the COVID-19 era. So Malawi is in the southern region of Africa, and is neighboring to Tanzania, Zambia, and Mozambique. Most of our cases have come through our imported cases. We've had a total of 101 cases as of today, with a majority being imported cases from Tanzania and people returning back from South Africa. So Malawi has 28 districts and 15 of these have reported cases. So we've had about 3,645 suspected cases. So about 3% of these have tested positive. With regards to what's been going on the ground at the community level, we haven't had a lockdown. However, our president did declare a state of emergency on the 20th of March, and we reported our first cases on the 2nd of April. Since the declaration of the state of emergency, there's been promotion of a health service hotline, which has always been in existence, but has been promoted more now for COVID use, and people are being advised to use the hotline and not present to the health facilities if they have COVID symptoms. There's been a lot of COVID education and awareness, policies on reducing numbers of people meeting at public gatherings, social distancing in public transport, which, like Helen talked about, has resulted to an increase in our bus fares. So our Queens is a public health facility, and most of the patients we see will use the bus to come to us. There's been closure of schools, and anecdotal reports about increase in child abuse cases that we've seen at our one-stop service, which is essentially where we review our child abuse cases. There's been a lot of COVID-19 associated stigma directed towards healthcare workers, directed towards people who've been diagnosed with COVID, directed towards people who've returned from affected areas. So people who've come back in from South Africa, from Tanzania, a lot of stigma directed towards them. And then we've also experienced a lot of the public declining testing, probably as a result of the stigma that they've observed and have possibly experienced. At a health facility level, we've scaled down, meaning we've tried to decongest our wards, and we are only admitting patients who really require it. We have tried to limit numbers of patients who are coming into our OPD clinics. There's also been a reorganization of patient flow within the pediatric department. We've closed a ward so that nursing staff from that ward could be moved to other wards. And we've opened up another ward, a respiratory ward, which I'll talk about later on. Our OPD clinics remain open, as do our immunization and under 5 or well baby clinic services. At a healthcare level, we've also had staff sit-ins. So this was in April, where Queen's staff had a sit-in for the purpose of, I guess, people were asking for PPE and for revision of risk allowances, which affected service delivery during that period. Queens is not the only health facility where sit-ins have happened. This has been happening across the country. So the Queen's Pediatric Department is one of 4 tertiary referral hospitals, and we have 9 pediatric wards with an OPD with a short stay. The picture on the screen is a picture of our short stay, and as you have seen, the team have really been trying to make things work. So our benches were painted so that we could achieve social distancing. We have an annual attendance of about 24,000 to our pediatric A&E. That's from 2019. And our daily OPD reviews are about 100 to about 150 patients. Daily admissions will vary and range from about 10 to 40 patients being admitted. And our peak seasons, we have 2 peaks for malaria and for bronchiolitis. So the malaria peak season is from December to April, and bronchiolitis is from February to March. During winter seasons, however, which are coming up, we do have an increased number in respiratory conditions, apart from bronchiolitis. Fever and cough are a common presentation amongst our OPD attendees and are present in about 50 and over 50% of our patients. So since the state of emergency was declared in March, we've seen a reduction in numbers, especially during the time that we had the sit-in. There was a reduction in numbers coming to our A&E, as you have seen. So April 2019, we had 2,245 patients coming into our OPD. The same this April, that's been halved almost. This is in comparison to the same 2,000 which were coming in January, February, and March. However, with regards to respiratory symptoms, we're seeing more or less 50% of our patients coming in with respiratory symptoms. So therefore, these could potentially meet the WHO criteria for suspects. We've admitted 62 patients to our other wards and 53 to, which is about 8%, to our respiratory ward. So this is a very complicated diagram, but I'm going to try to explain. So Malawi has a 3-tiered health system. So we have primary care, secondary care, and tertiary. Primary care includes health centers and community health care workers like environmental officers, and also HSAs, which is health surveillance assistants. So at your primary care level, you have your health centers, as I have explained, and your community health care workers. At your secondary level, you have your district hospitals, and then at your tertiary care level, you have your central hospitals, of which Queens is one. So Queens is in the Blantyre district, and the Blantyre district does not have a district hospital where pediatric patients are admitted. So basically, Queens acts as an admission for all pediatric patients in the Blantyre district. However, because of the nature, the public health relevance of COVID, most of the COVID health response has been done and has been championed by the district health office. So they've been championing the response at a community level, at point of entries such as borders and airports. And this is through what we call a district rapid response team. And this comprises of healthcare workers, but also other stakeholders such as immigration officers, the police, and transport. So they would have been working in the communities, but also in the borders. What's been happening at Queens is we've set up screening and triaging, and if patients have met a criteria, they've been isolated. So prior to the hospital scaling up its screening services, the pediatric department had started screening patients, and patients were being cohorted if they met the criteria in what we have called what we have designated as a respiratory ward. So any patients coming in with fever and cough is being sent to that respiratory ward. However, if that patient is then tested and is confirmed to have COVID, that patient would then be taken to our infectious disease treatment center, which isn't located within Queens for the public. So that's outside Queen Elizabeth Central Hospital. So now with the changes that have come is we've now started screening at the hospital entrance, and patients who are screened positive will be taken care of in a separate COVID pathway. And once they are screened positive and suspected to have COVID, and a decision is made to manage as such, they will then be transferred to the infectious disease treatment center. And the infectious disease treatment center is under Blantyre District Office. So it's not under the mandate of Queen Elizabeth Central Hospital. However, they will consult pediatric expertise where required. So this picture shows the area that we have designated as our COVID-19 pathway. And it shows basically we're using tents, and we haven't had any permanent structures erected. So everything is tent area. So as you can see, patients will come in through the gate and they'll be screened. All health care workers will also be screened. So when it's being fully implemented, the plan is to have separate screening for healthcare workers and for the public. Once they've been screened, they'll basically be channeled to what is the COVID pathway or the red zone, and everything will be done there. So there's also a holding site for patients who have been stabilized if they needed it before they're transferred back to Gameza. As of now, patients with mild and moderate disease are being isolated at home if they're presumed to be low risk. And then patients with severe disease requiring hospital admission are being admitted at our infectious disease treatment center, which isn't located within Queens for the public. However, if a staff screens positive, they are taken straight to our ENT ward, which we have renovated to be used as a ward for COVID services for healthcare workers. So regardless of whatever severity of disease they have, that's where they'll be taken care of. Patients who are healthcare workers requiring hospital admission will be admitted in that ward. However, those who have mild and moderate symptoms will be isolated at another facility, which isn't a medical facility per se, but it's just been adopted for isolation. So we've adopted a single point of entry screening as per WHO recommendations, and we have designated the hospital into red zones, orange zones, and green zones, the same as what Helen had shown in her picture. So red zones are areas where you're taking care of patients who could have COVID. So this includes respiratory wards and the COVID pathway, which I showed you. Orange zones are areas where you have mixing and you're not sure what's going on. So the gate could be one of those places. And then green zones are areas where you're making an assumption that we're not taking care of COVID suspects, though it's very difficult to differentiate and delineate who has COVID and who doesn't. So we're also using this system to guide the level of PPE that you need for the area that you're working in. So we have extended PPE for the red zones, which is a full set of PPE, and then you have a downscaled level of PPE for your green zones. Once patients have been flagged at screening, they're being isolated if they have fever and cough. This, even if patients didn't have an epidemiological link, we were separating all patients with respiratory symptoms and cohorting them in the respiratory ward. And so that was serving as an OPD, but also as an admission area for all patients with respiratory symptoms. So after review in that ward, some patients were being sent down to the ward once the team felt that they might not have COVID. We initially were not testing all our patients in the respiratory ward, but in the context of now having more cases and documented community transmission, we are testing all patients who do come in before they are sent down to the ward. So testing has been based on suspect criteria. So if patients have met the suspect definition, and as I've now explained, because of community transmission, so B and C definitions of a suspect now apply, and so testing has become extended. We have 2 labs in the Blantyre district, and our turnaround time for results is very variable. Could be from about 4 hours to about 24 hours. So the challenges that we've had navigating through pediatric care have been, 1, healthcare worker anxiety. So we've had a lot of low morale amongst our staff, a lot of fear, and that's been stemming from fears about getting the disease, fears about taking the disease home, fears about being separated from your family. So if you work in a red zone, our government guidelines are basically recommending that you do not go home until you have been released from your duty station, have been quarantined for 14 days, and are declared to essentially be COVID-free. However, people are being given an option to go home, but our guidelines have been changing all the time. So the Ministry of Health has been rolling out a healthcare worker training, case management of COVID-19, and part of that training has sessions on psychological first aid for healthcare workers, but also teaching healthcare workers how to administer psychological first aid to patients. And that session basically allowed healthcare workers to voice out their concerns, to voice out their fears, to validate their fears that they have, and has been very useful in navigating through the difficult time that we're going through. We've also had debriefing sessions at ward level, and so these have been essentially the same thing, letting people voice out their fears, their concerns, any disagreements with evolving guidelines, with changes that are happening within the department, but also questions to demystify some of the things that have been going on, that have been publicized in social media. And the other challenges that we've had have been rebuilding team spirit and staff morale. Excuse my spelling on staff morale, because it's been low, and as I've said, we've had to move around staff, clinical and nursing staff who usually don't work together, who usually might not know how to work in a particular ward. So that requires getting used to working together. So there's been a lot of team building activity that's been happening within the pediatric department. We've also set up a respiratory ward, which has required mixing of OPD and inpatients. So the department already works with very limited numbers of healthcare workers. So this has put a toll on the workload even more. And so we are also still navigating around different rotas. We've created a rota that separates healthcare workers working in the respiratory ward and those working in the rest of the wards, so that we are not mixing. So this is both for clinical and for nursing staff. I've talked about reallocation of clinical and nursing staff, and then there's also been dilemmas about extending testing, which we have now adopted. We've adopted extending testing for patients who are in the respiratory ward. Before they are sent down to the other wards, they are being tested. If it is concluded that what they have is not primarily a respiratory condition, and could have been cardiac failure, could have been chronic lung disease, could be TB. The child also has malnutrition, and they're better taken care of in another ward. So patients are being tested before they're sent down. And also because of the issues of stigma leading to concealment of travel or contact history, which has been experienced, we think that before patients are sent down to the ward, they should be tested to protect healthcare workers. Because I've said in the green zone, the healthcare workers have a downscaled level of PPE. However, in the context of community COVID, once again, these guidelines might change. So there's also been a lot of discussions about doing or not doing CPR. So what we have opted to do is if a patient has confirmed COVID, we will not do any CPR. However, if they're only suspected to have COVID and you have the appropriate PPE, being either an N95 or high level of FFP mask, you will proceed to do CPR. CPAP is being recommended amongst our COVID-19 patients. So we have bubble CPAP in Malawi. However, the dilemmas will be in the numbers that we have available. So unless we have new stock that we can send to the Infectious Disease Treatment Center, it will be difficult to implement CPAP in COVID confirmed patients. Because we reuse our tubing, there's also these issues about infection prevention control and proper sterilization and disinfection of the tubing, which potentially is something that we'll have to navigate through and discuss further. For patients who have respiratory failure, despite getting CPAP, the decision was not to escalate to the ICU. So we have a 6-bedded ICU, which is located at the Queen Elizabeth Central Hospital. So the decision right now has been to not escalate respiratory support further than CPAP. Setting up a pediatric admission service, as I've said, Queen's has always acted as the mentor and as the inpatient admission service for Blantyre District. So now Blantyre District Office is taking on this role and we essentially require one, ward space, equipment and expertise, pediatric expertise and experience to be able to manage pediatric patients. To date, we haven't had a confirmed case of COVID, a pediatric case. And the youngest patient we have had in Blantyre District is 17 years of age and has otherwise been fine and has not required facility isolation or facility care and is at home. So this is uncharted territory for us and we'll have to navigate through it. Thank you very much. That was what I had.
Fantastic. Thank you so much, Jess. That was wonderful to hear about all the hard work that you've been doing here. I apologise for everyone that we have overrun. Since we've been answering a lot of, Helen and Stephen have been answering questions on the questions app as we go along. I'm just going to ask if anyone wants to raise their hands, if anyone feels that there's any questions that we haven't answered quickly. I'd also say that if you need to go, please do email us with your questions and we will pass them on to the speakers. And we will make sure that when we do the next webinar, we keep to time. So yeah, any questions for our panelists? Maybe Stephen, Helen, Jess, you could put your videos on. No? Great, thanks. Hi, anyone else? Any questions? Great. Okay, so one question we've had on the app is, what are your centres doing in terms of management of potentially symptomatic caregivers?
There was a question, this is Stephen here, from Umanasur Suleiman about a negative swab excluding COVID.
Oh, yeah.
Just to say that no, a single negative swab doesn't exclude COVID. And if you have a patient who is still symptomatic, particularly if they are very early in their illness, it might be worth repeating that if the swab is going to change your management in some way.
Great, thanks.
Oh, hello?
Yes, great, thanks.
Sorry, I got disconnected there. Yeah, just to say that I think a lot of questions about swabbing. I think just to emphasize that, you know, doing the test is only relevant if it's going to alter your management in some way, either in terms of patient flow or because there's a particular debate around specific management. But in the vast majority of cases, children with this illness can be managed as with any other viral respiratory infection. There's nothing particular about it. The reason for testing is so that you know who's positive in order to safeguard your staff and other patients.
Great. All right, I've just seen, thank you. I've seen one more question. I'm just going to ask. Here you go. Hi. Okay. So Natalie has asked, can we have info about the scuba kits and will you publish them? Is that for Helen?
Hi, yeah. So this really came out of some work that was done in Italy. You might have seen on social media these kind of improvised scuba mask, CPAP masks they were using during the peak of the outbreak there. So we started looking into this when back in March, we couldn't find any supplier to give us CPAP because there was a shortage. So we looked into kind of innovative solutions. So we've been working with a 3D printing company using 3D maps, which you can get on the internet. I mean, it's very innovative and that they're not ready for use yet. And just a word of caution that, you know, anything you innovate obviously has to be tested. So you need to make sure that the pressure that is delivered through a PEEP valve is reliable and can be calibrated. You need to make sure that that the filter you have in place, so we imported HEPA filters, is not going to aerolize and release more virus into the environment. And also that the oxygen levels that you're delivering and the CO2 clearance is all, you know, within limits. So it's actually very complicated. We are still developing it, and hopefully we will use it, and the biomedical department is going through all the testing. But we will, if there are options to procure other verified manufactured CPAP machines, we're also looking into that.
Great.
But I'm
fantastic.
happy to, you can contact me directly if you want more information.
Fantastic, thanks. I think we have someone's got their hands up. I think, Paula, you're going to unmute. Umalnasur, I apologise if I'm not.
Hi, thank you for the very informative webinar. I think it's very very optimistic to see how other countries, I'm from Sudan originally, so it's very informative to see how other countries are tackling the disease. Just one last question about the reinfection have there been cases where have tested positive for COVID and have had a negative swab and have presented again, either in adults or children?
Hi, Jessica, did you want to take that one?
Okay, so I know about data, and Stephen he's muted it, but I know about data in China where they've had sort of a second wave in COVID cases that they've seen, and they've documented cases of patients who were COVID positive, became COVID negative, and then later on represented and were COVID positive again. But people are not sure whether this is reinfection or whether this is testing, whether it's as a result of testing. So as of what I had read recently, there hasn't been any evidence of reinfection or support for it. But the recommendation is once you've been infected to continue IPC and social distancing and all the recommendations for COVID prevention. So I don't think that has been established yet.
So we don't know if they're infectious again or not?
No, from data that came out of China. So that's the evidence that I had read. So it hasn't been established yet whether once you've had COVID, you can get reinfected.
Yeah, just to come in there, Jessica, that was my understanding as well. And I think really what we need is serology studies. I mean, what you need to see is the serology and then later on and track the antibodies to see. And another thing about testing, which Stephen also mentioned, is, you know, it's not just the sensitivity of the actual real-time PCR, it's also your sampling technique. And if you're not getting, you know, right to the back of the nasopharynx, then you know, you risk having a negative test. So we've had one case where we strongly suspected. We did one test, it was negative, we kept him in isolation and then retested the next day, and he actually turned out to be negative on 2. And then also we looked at the full blood count, which wasn't indicative of COVID. This was an adult. So, you know, you can use different pieces of the puzzle, and then with 2 negative PCRs, you might be reassured.
Great,
Thank you.
So I think I'm going to finish with one final question, which has come up on the chat, which I think reflects definitely what I'm wondering at the moment here in Malawi. So Helen, you mentioned that the modelling from Gambia anticipated much higher numbers than currently seen. Any thoughts on the trajectory, or is it impossible to generalise across different areas of the world?
Yeah, I mean, it's taken us all by surprise, and I think probably each situation is very unique. But I mean, we do think that the shutting down the borders and stopping the number of imported cases early definitely had an impact. And we do have the ability to do a lot of testing here. You know, the fact that so many of our cases are asymptomatic means we're probably picking up a lot of people if we weren't testing that we would never know, and then you get community transmission. But I think some data from Europe and China is that actually the virus was circulating long before it was officially picked up. I mean, there was reports from France of early December, and I think the advantage that we've had in, you know, a lot of African countries is we've been able to do this a lot of testing early on to try and pick up these asymptomatic cases. I don't know what others think.
On that point, Helen, but one thing that I've been wondering is, because we reported our first cases on the 2nd of April, so we're about 2 months into it, and we haven't had an increase in number of respiratory admissions, respiratory infections being seen, unexplained deaths. So I've been wondering about, because China had an increase in number of respiratory cases being seen, atypical presentations that they had not seen before prior to testing. But I just wonder, the same for you, whether you have experienced an increase in number of respiratory infections in the...
No, we're not seeing it. I mean, it's complicated because people also might not be accessing healthcare, but from what we're seeing coming to the clinical services, we're not seeing a peak in lots of pneumonias. Yeah, I mean, I think there's a lot of unknowns, aren't there? There was some data that came out this week about, you know, outdoor environmental temperature and whether the sun actually inactivates the virus in outdoor places. You know, I think the next few months are going to be really critical for understanding this more. Great.
Okay, fantastic. So I think we better call it a day as we've run 25 minutes over. Once again, sincere thanks. One, for everyone who's attended and asked questions, but also particularly for our panelists who've given up a lot of time to prepare for this when I'm sure they are incredibly busy. And also for my co-host Paula, who's been doing the technical know-how at the end. Just to say, we have another 3 webinars planned, so please check on email and Twitter. We'll be publicising them soon. And ICHG, we've been talking a lot about the indirect effects of COVID on children, and that this may be a catastrophe. So ICHG are preparing a number of advocacy initiatives at the time being, which we will be at the time which we will get out soon, and we'll be very grateful for people's support of. So great, thank you very much, everyone. Thanks so much.
Thank you.
I'm going to end it now. Thanks. Thanks.